Hello, my name is Gabriela Rivas, and today I will be presenting a 6-year-old female with the initials of AH. This is an episodic soap. So AH is a 6-year-old female who comes to clinic with complaints of a rash for 5 days. She is brought in by her mother, and her mother is her primary historian. Mother is deemed a reliable source for information. Chief complaint. AH has been complaining about her rash to her arms. She says it's very itchy and nothing makes it better. History of present illness. AH started with symptoms 5 days ago. Her mother, child goes to daycare daily after school, Monday through Friday, and this is the 3rd time that she has gotten this type of rash this year. Review of systems. General. No sudden weight loss or weight gain. Her growth is normal. Her speech is appropriate for age. No concerns with vision or hearing. Skin and lymph. She has an itchy rash to both arms. No adenopathy, lumps, bruising, or bleeding noted or verbalized. HEENT. She has itchiness to her scalp. She does not have headaches, no conjunctivitis, and she did not have a sore throat. Cardiac. Denies heart murmurs and cardiac issues. Respiratory. She denies history of pneumonia, bronchiolitis, wheezing, or shortness of breath. GI. Her stools are normal, no nausea, vomiting, or diarrhea. GU. She denies frequency, dysuria, and hematuria. Musculoskeletal. No fever, denies joint pain or weakness. She has no known allergies. She is currently not on any medications. Her prior history, no hospitalizations. Her vaccines are up to date. Her family history includes mother and father and 4 siblings live together in an apartment with 2 bedrooms and 1 bath. No one smokes in the home and no one drinks in the home. So her vital signs, her temperature was 97.6, her heart rate was 105, her blood pressure was 90/50, her weight was 18.3 kilos, putting her in the 40th percentile. Her height was 41.75 inches or 16th percentile. So for my physical examination, she is a female with notable lice in her hair. She is dressed in her school uniform, clean, appears her age. No apparent distress noted, although she is continuously scratching at her arms and her head. Physical exam. Her skin is pink and warm, no cyanosis noted. She does have severe erythemic papules and areas of scabbing to both arms. I did notice pigmentation changes to the antecubital folds bilaterally. She does have areas of scabbing from the constant scratching. Her head is normocephalic, atraumatic. Her hair is long, pulled back with visible lice moving and visible nits. Her eyes were normal. ENT, no pharyngeal erythema. Her dentition was normal for age. Pink mucosa. Her respiratory status was normal. Cardio, she had a regular rate and rhythm. No murmurs, rubs, or gallops. Her capillary refill was less than 2. Abdominal. Normal bowel sounds, no issues there, soft, non-distended, non-tender. GU, she denied any issues. Musculoskeletal, she can move all extremities equally, and her spine was straight. Neural, she was alert ×3, and she had normal reflexive syndrome. No labs were done. So my differential diagnoses were, number 1, pediculosis due to pediculus humanus capitis, which is B85.0. So for pediculosis due to pediculus humanus capitis, my clinical discriminating key features were she's a 6-year-old female. She attends daycare Monday to Friday after school. She had the itchy scalp. She had the itchy rash times 5 days to both arms. She had visible lice and nits on her hair. She had the erythemic papular mat rash to both arms with discoloration and scabbing to the antecubital folds. She's constantly scratching at her head and her arms throughout the visit. Classic clinical findings include infestation in a family member or daycare, which her sister does have the same infestation, dandruff-like substances in the hair, itching of the scalp, and feeling that something is crawling on her scalp, and visible lice in it. So treatment plan using current guidelines. There are various treatment options due to treatment failure. So the first line of treatment and the treatment of choice is a pediculicide with proper application. So mom was informed not to shampoo with conditioner or cream prior to treatment. She was to apply the permethrin 1% to damp hair, not to wet hair, because applying it to wet hair would dilute the solution. She was asked not to rewash the hair for 1 to 2 days after applying the treatment, and if needed, she could reapply in 7 to 10 days. Okay. So with the permethrin 1%, she's going to apply it, leave it on for 10 minutes, and then rinse it. She cannot wash the hair again for 1 to 2 days, as mentioned before. She will also use a fine tooth comb for nit removal. She's supposed to comb damp hair for 20 to 30 minutes, working from the top of the scalp towards the bottom, and it should be done every night for 2 to 3 weeks. And she was also asked to examine other family members. Another important guideline was to wash any linen or clothes used within the last 48 hours with hot water and put it into the dryer for 20 minutes. She should vacuum her home, and she should also place items that cannot be washed. She should place them in a sealed plastic bag for 2 weeks. So the medication used was a permethrin 1%, apply for 10 minutes and rinse, and may repeat in 7 days if lice are still present. And for her rash to her arms, we can give her permethrin topical 5% cream, applied to the entire body from neck down, including behind the ears, under nails, once a day for 7 days, then 2 times a week until cured. So my second differential diagnosis was scabies, B86. So clinical discriminating features for scabies include also she's a 6-year-old female. She attends daycare Monday to Friday after school. Itchy scalp, itchy rash for 5 days to both arms. Again, visible lice, nits in her hair, the erythemic papular rash to both arms with discoloration and scabbing to the antecubital folds, and the consistent itching of her arms. Classic clinical findings for scabies includes curving S-shaped burrows at the wrist, ankles, finger, webs, forearms, areolas, anterior axillary folds, genitalia, and proximal half of the foot and heel. Vesicopustular lesions to above are also noted. Mentioned areas and secondary lesions include itchy papules from inflammatory responses. So some diagnostic studies that can be done include microscopic examination of the scabies from an unscratched burrow in saline or mineral oil, or the burrow ink test. So what you do with that is you apply a drop of ink across the suspected burrow, wipe off the excess, and examine with a magnifying glass. The clinic that I'm at does not perform these diagnostic studies. So the treatment options for this was the permethrin 5% cream to the entire body, avoiding the eyes, paying special attention to the underneath the fingernails, the scalp, behind the ears, and all the folds and of the feet and the hands. We educated mother on proper use of the cream by explaining to apply a thin layer to the entire body from the neck down and rinsing after 8 to 14 hours. So primarily putting the lotion on right before bed and then rinsing in the morning. Mother may repeat this process in 1 week. And again, the same as with the pediculosis, she should wash any linen or clothes used within the last 48 hours with hot water and then put them in the dryer for 20 minutes. Again, vacuum the home, and items that cannot be washed should be placed in a plastic bag for 2 weeks. I also informed mother not to overbathe the child because that can also make her rash worse, and let her know that the itching can persist for 3 weeks after treatment. So the treatment for this was a permethrin topical 5% cream for scabies. The dose was applying the thin layer to the entire body from the neck down, including behind the ears, under the nails, and all the folds once a day for 7 days, and then 2 times a week until cured. So my third differential diagnosis was papular urticaria, or AL 50.8. The clinical discriminating key features included she's a 6-year-old female, attends daycare Monday through Friday. She has an itchy rash times 5 days to both arms. On physical exam, she had the erythemic papular rash to both arms with discoloration, scabbing to the antecubital folds. She's scratching at her head and her arms throughout the visit. Classic clinical findings include erythematous papules over shoulder, upper arms, legs, and buttocks, and it can last for 46 months. So treatment plan includes removing the offending insect if they can figure out what it is. Another treatment is applying topical corticosteroids and administering oral antihistamines. So my medications included diphenhydramine for 6 to 11-year-olds. The dose was 12.5 to 25 milligrams PO every 46 hours as needed. The concentration used is 12.5 milligrams per 5 mLs. So the dose to be given is 5 mLs PO every 46 hours as needed. And for the steroid, the corticosteroid, I picked prednisone. It's 1 to 2 milligrams per kilo per day for 1 week. So I'm using the 1 milligram per kilo per day. The concentration is 5 milligrams per ml, and the dose was 3.6 mLs once a day for 1 week. So after reviewing all my differential diagnoses, I believe my diagnosis was first pediculosis due to pediculus humanus capitis and scabies, along with the treatment that was provided earlier. I did agree with the diagnosis. I believe the treatment guidelines were followed. Something I would have done differently would have been to request a social services consult just to identify resources available to this family. This was a family who lived in a 2-bedroom apartment with 5 children and both parents in the home, and they did attend daycare. So I was hoping that maybe social services could speak to mom and find out if maybe other children were affected at the daycare. Maybe cleaning needed to be done, and maybe they could have helped with that process. Mother was supposed to come back in a week. I wasn't at clinicals that day, but I do know that she did return and that her child's skin did look better, and the lice were going away. And I believe that is it for my presentation. Thank you.